Welcome to Be Well with MS podcast. I'm Dr. Agne Straukiene, your host and a neurologist dedicated to bringing you the latest insights and advancement in multiple sclerosis care. Before we begin, I'm a consultant neurologist at Torbay and South Devon NHS Foundation Trust. This is where the PARAMS study is being hosted, and Exeter University's leading work package for technical validation study of PARAMS study. I want to clarify that Be Well with MS podcast is not affiliated with Torbay and South Devon NHS Foundation Trust. It is a podcast that I'm committed to enhance people with MS and their carers' knowledge and share information. Today, I'm very excited to have as our guest, Associate Professor Will Young from the University of Exeter. Dr. Young has an extensive background in rehabilitation psychology and is at the forefront of innovative research in falls prediction and prevention, particularly among individuals with neurological conditions. His work with augmented reality, AR in other words, and motion tracking technologies has a potential to revolutionize how we assess and treat motor functions in multiple sclerosis patients. In today's episode, we will delve into the MS PARAMS Phase 1 study, which aims to validate the use of AR and motion tracking in assessing both motor and cognitive functions among MS patients. We will explore the study's objectives, the integration of these advanced technologies, and the potential impact on MS care. Will, thank you for joining us. Let's start with a bit about your journey, and can you just tell us more about what led you to get into the augmented reality research field?
Well, hello. Thank you for having me on your podcast. It's a pleasure to be here and to be talking to you about this. I have a bit of a wiggly journey, if you like, through to this work on AR, particularly in MS. I did my PhD looking at eye movements in older adults as they walk, and looked at the effects of anxiety on the way people move their eyes to pick up information from their environment. And then I started to look at these behaviors in people with neurological conditions, particularly people with Parkinson's. And through this work on Parkinson's, I came across there's a well-established field of research known as sensory cueing, where it seems as though people can improve the way that they move, particularly with walking, if they move to something in the environment. So some form of sensory information, whether it's the sound of a marching beat or visual lines on the floor. And it's this work in Parkinson's that connected me with the Stroll, which is the company in this project of PARAMS, where they designed visual cues for Parkinson's originally using this AR device. And here we are working with these AR tools in the context of the balance and walking. We started to do this work together on Parkinson's, but the discussion quickly progressed into MS, and that's where we are today.
Wonderful. This is fascinating world that you are involved heavily doing the research, and your previous experience in the Parkinson's disease field, I think, is only a huge advancement for us to work together and to develop the tools that could be applied and used in the multiple sclerosis field. So thank you for your eagerness, your knowledge that you're keen to share with MS community. And I think it would be useful perhaps to talk and look at the whole sort of a project overview of MS PARAMS Phase 1 study, and look at what is the primary objective? What is the plan to achieve with this study? What stimulates our thinking? What do we want to get out of it?
Yes, absolutely. So the ultimately within the PARAMS project, we want to be able to get to a point where we are taking these AR devices into people's homes and know that the information that we're collecting is accurate. Not only are the devices, are they feasible for use in the home and things, but ultimately we need to be sure that the information that they give us is accurate. And this is the purpose of the first phase of the project that we are running in Exeter. So this is known within the project as the technical validation, and we need to know whether the sensors within the device are accurate enough to give us meaningful information about, for example, the way someone is controlling their balance. If we look at postural sway, the step-to-step characteristics as people walk. At the moment, we don't know for sure if the device is giving us information that we can rely on sufficiently enough to make clinical decisions. And also, this device is going to be feeding information back to the users, people with MS, and we need to know that that information is reliable as well. So that's what we're going to try and do in this first phase.
Wonderful. I think it's a great foundation for moving forward into the clinical phase of this study. For people who are not very familiar with the PARAMS, what does it stand after PARAMS? So it's a care closer to home, motor function parameters from augmented reality supported assessments in people living with MS. And that's how this name is born. It was an idea from the professor in Amsterdam, Melvin, right? So he proposed this name of the study.
Yeah, that's right. Yeah, Melvin Roedink. Someone that I've known for a long time. It leads the scientific processes in Stroll. A wonderful researcher, and it's a part of a great team that's been put together for this project.
Wonderful. So it's almost like international project, isn't it? It attracts a lot of attention overall. People get super excited because it's a very innovative way of assessing people at people's home using technology to define and detect very subtle changes of neurological status and assessment, which is part of the inspiration of the integration work of augmented reality and motion tracking technologies to assess the motor function and cognitive function. So do we believe that AR is much better than EDSS, which is our expanded disability status scale, to assess the patient methods? Are we ambitious enough to state this as yet, or the technical validation study will give us a bit more evidence? Are we planning to challenge the EDSS and say, look, it's not sensitive enough? What are your thoughts on this?
I'm not an MS expert by any means. I can only really speak to the literature search that we've done, looking at studies that have used the EDSS and the criticisms people make of that tool, and then also the sensors, the hardware within these devices. We know about how accurate they are in terms of looking at the accelerations or movements that people make. So we can have a pretty good guess that these sensors are going to be pretty accurate, especially when looking at the timing of movements. So if we're looking at the timing of steps, for example, or if people are turning around when walking, we can look at the timing of the different movements of the different body segments, for example. So we can already say that that's pretty accurate, and it's not something that the EDSS will really pick up on. I mean, the real benefit of the EDSS is, while it's a subjective assessment, meaning the observer, the clinician, is forming a rating of the movements or the different aspects of the task according to their expert judgment. That's clearly a benefit because you get the expertise of people like you, Agne, who have that insight being able to perform that rating. The AR device doesn't have that insight, especially not at the moment. So we do have the benefits of the accuracy of the sensors, but it's knowing what to do with that information that's going to be critical. And so in this first part of the project, we're just going to look to see how accurate are these sensors at determining these different, or getting these measurements of these different movements. And we can ask the question, or how well do these scores that come from these sensors, how well do they really associate with or how close are they to the EDSS outcomes? So I'm not really in a position to say whether one is better than the other. I think there's going to be pros and cons of both approaches, but it seems pretty clear to even a non-expert in the MS field, such as me, it seems pretty clear that there are significant shortcomings of that EDSS tool, and that the AR device, the way that it collects information and in a way that allows people to perform these tasks which are representative of the types of movement that they'll do in daily life, that seems to be a big bonus that will overcome some of the problems with the EDSS. I think it's fair to say.
Yeah, absolutely. I agree. And I'll give you a bit of a reference and from the clinical perspective from what happens in my MS clinics when we perform the EDSS. To do that precisely and accurately, it takes at least 40 minutes. How many minutes do we have per consultation? 15 minutes. And some services have a bit longer, 30 minutes. So it's not enough time to perform the EDSS in a very detailed manner. So, and we may have some bias and some subjectivity involved in assessment, and each neurologist may have different approach and different assessment, and that gives a lot of variability, and that might be misleading outcomes when we make the decisions towards the patient's management. And also, the EDSS may be 0 on our books. We do, let's say, neurological assessment, and we find this is 0 because patients may be physically fit and well, everything is perfect, but the cognitive function is deteriorating, and that doesn't trigger the EDSS to be higher than 0. And it's a common real world problem. And we're trying to, by running the study, to establish the methods that we could identify unbiased data that could help us to enhance our management plan, to make decent, smart decisions towards brain health and improving patients' outcomes. And I think this is really important message. And I think overall, with all the clinical trials and studies, there are some challenges involved. And I wonder if you could forecast a little bit what could be technical challenges that you may face in validating the tool.
Yeah, it's a really important question because it's easy to talk about these modern devices as if they're going to be a really short-term solution for all the different shortcomings of the current assessments that we have. And they certainly do a very good job in measuring some things, particularly the timing of movement. But the way that the sensors work that are currently in this AR technology, they are less accurate when it comes to spatial assessment. So the most common example would be for walking. The sensors will be very good at picking up the timing of the footsteps, but not necessarily as accurate at looking at the length of the steps. And that might be important when it comes to looking at the variability of steps as people walk. So clinically, that's an important thing to look at, whether people start to walk with one shorter step, then a longer step, then a slightly shorter step. And it will be useful to be able to pick up on that. Within the technical validation, we can compare the outcomes of the AR device to sort of gold standard laboratory grade equipment, where we put these shiny reflective markers on people's bodies. We sort of stick them on with tape over different parts of their bodies, and we can then form a three-dimensional skeleton, if you like, them moving, and we can make very, very accurate measurements of both the timing and the spatial aspects of their movement, and we can use that to look at how accurate this AR device really is. So I think that's going to be one of the key challenges in terms of looking at the potential weak spots of the AR technology. But I'd be keen to stress that it's not that we need the AR device to be as accurate as laboratory grade equipment. The key is that it needs to be accurate enough to inform a meaningful clinical interpretation. So there's a very interesting discussion that's going to happen once we know how accurate those sensors are at delivering those outcomes. We can then have a discussion about what makes the grade in terms of what gets reported as part of the PARAMS tool.
Yeah, wonderful. And for our audience who never ever faced the augmented reality, what does that involve? How does this device look like? What do you put the glasses? Do you put some sort of sensors around your body? Do you strap yourself? Can you just describe in simple language for people who never seen the AR gadgets? So how does that look like? What does it involve?
I would say in my time with VR and AR, I've never really had to describe this to people because the previous studies that we've done have all been with virtual reality with people with Parkinson's, where we've all seen images of virtual reality goggles, which are like a huge set of ski goggles that have sort of computer screens inside them. So, and that's what you look at. But with AR, the goggles are a little bit more lightweight, and it's a little bit more like, imagine if you're putting a set of ski goggles on and then you pop out the mask, so you can actually see through the ski goggles to the real world. But the amazing thing about AR is that the technology can superimpose images on top of the real world, so that you might be walking around your lounge and seeing your home as you normally see it, but you might have some extra targets to step on, or information that might be designed to help with movements, or specify a task for you to interact with that allows us to measure your movements as part of these clinical outcomes. So imagine a ski goggle mask with the sort of the screen popped out, and that's probably the closest I can get to it. I would add, though, that one of the challenges, I suppose, with studies like what we're doing relates to how quickly this technology is progressing. So right now, these goggles look like ski goggles, but in the future, probably 10 years down the line, we're going to be looking at devices that look very much like normal spectacles. So I would say that the PARAMS project, one of the real strengths is we're trying to get ahead of the game, if you like, of designing the nature of the tasks and the assessments, not with a view that people will be using these ski goggles for very long. It will be the case that in the years to come, these PARAMS tasks and outcomes will be gathered using much more lightweight, portable, easy to use hardware, just like a normal pair of spectacles.
Yeah, and I would like to also highlight that VR glasses are completely different from AR glasses. Okay, virtual reality glasses would block you from the real world, so you actually can't see what's around you. Where the PARAMS study uses augmented reality glasses, and that penetrates. You can still see the objects around you, but it gives you some extra holograms and some objects. But you still live into that your own sort of space. You can see around everything very clearly. So, and that minimizes the feeling of dizziness, because some people have real sort of a seasickness, when they push the VR glasses, because it sort of blocks you from the reality, and you are engaging with various different games. For example, some people hold VR lenses, or their kids have that at home, and that can give a bit of a giddiness feelings, where AR minimizes that effect, because your visual spatial awareness is still present. You can see the objects around you. What's your experience in terms of the side effects from using the AR? From the Parkinson's disease perspective, any sort of potential balance and coordination issues when you push the goggles on or not? What's your experience, Will?
I think people like Melvin would be better placed to talk about the use of the AR in Parkinson's. Certainly for us, we don't see too much evidence to suggest that people will experience dizziness. I mean, just like you described, you're looking through what is effectively a very thick-rimmed pair of spectacles with a head strap, which means that you're not just able to look at the thing that you are fixated on at any time, but you also have a large degree of your peripheral vision, and that's something that was very important for maintaining balance. So all the information is there from vision that you would typically have, which means that you don't seem to get side effects such as dizziness, but that can be a big problem with VR, because like you say, you're shutting off the whole of vision and then presenting information that can be a little bit of a mismatch with virtual reality information that you're presenting, and what people are the information they're getting from their other senses, like the sensation in their legs, for example. There might be a mismatch there, and that tends to be what causes dizziness.
So really, for us to draw the conclusions and make this tool valid, we need participants at this clinical trial. And I'm sure that half of the audience now listening to this episode is like thinking, ooh, I would like to be involved. That sounds fascinating. And if I could contribute to the research project, that's the only advancement for the researchers to develop better tools to help clinicians to personalize treatment management. And I think this is all about how can we best enhance quality during the clinical consultation? How can we shorten certain steps within the clinical space to allow people to have, or to allow people with MS and clinicians to have decent discussions and focus more on what can be done to improve outcomes. But without knowing the data or biology or underlying mechanisms and mechanics of the gait, is difficult call for the neurologist to draw the conclusion and make the robust plan, whether it involves changing maybe disease-modifying therapies, maybe it will involve initiating disease-modifying therapies, maybe that will involve enhancing the symptom management, getting the physiotherapy input into the whole sort of management living with MS. So it's a really important study overall. And I just want to maybe a bit of a forecasting and discuss with you, Will, about in the ideal world and in general, what are the expected outcomes and how can we enhance our understanding of MS-related cognitive or motor impairments? What's your sort of prediction?
So this the outcomes from the technical validation or PARAMS in general?
Yes, technical validation.
From the technical validation, I mean, like I say, we'll know more about how accurate these sensors are at delivering the whole series of tests that we plan to generate from the PARAMS tool. We'll know which aspects of which tests are accurate or less accurate, and that will inform future development. So one thing that comes to mind is if people maybe have tremor or a certain characteristic of their walking that may create error in the way that we measure it. What we can do going forward, following the technical validation, is being aware of that issue, we can develop the software further to overcome those issues going forward, so it becomes more suitable for use in the wild, in people's homes. So coming from the technical validation, we're really just preparing the PARAMS tool for use in a way that's feasible in people's homes. But going forward from that, I mean, the PARAMS tool in general, what we are talking about is a device, like you say, the EDSS takes quite a long time, longer than the clinical appointment. We're talking about a tool that, given a relatively short set of tasks, I mean, I say relatively short, like 15 minutes, of a few different standing and walking tasks, we can create a whole series of outcomes that is a lot more detailed in terms of the number of outcomes compared to the EDSS. And that might be really useful for flagging up issues where people may need to see a clinician. And this flagging of issues, it may be something that doesn't get noticed or flagged straight away otherwise. So if an issue does emerge, the PARAMS tool may be able to pick up on that, and then people can get arrange an appointment and get maybe any changes in the treatment that they receive sooner. That will hopefully be a benefit. But one of the other benefits of this ongoing monitoring in people's homes is that you then have these accurate measurements over time, so you can look at progression of certain symptoms and get a much more accurate picture when the person with MS or the clinician looks at that trajectory of these different outcomes over time. It just gives a lot more information to inform the decision-making process in healthcare.
Wonderful. I think this is really important. And as we know, time is brain, and knowing patients at the early stages of maybe early signs of the progression allows us to intervene with a powerful medicine that we have available. And the sooner we know, the better the outcomes are, generally speaking, for people with MS. And I think, and I would like to sort of forecast that it will allow to identify subtle things that maybe human brains and the current tool that we have, EDSS, we're referring always to EDSS, that's our sort of day-to-day bread and butter. But I think our prediction at this moment suggests that the AR tool potentially has got benefit. It may be a more sensitive sort of identification and assessment tool than EDSS. And that's it's ambitious setup goal that we have in place, but we would like to believe that this is the case, and we will be able to personalize patients' care plans, identify patients at risk, and bring them into the clinical space to discuss the ongoing management and change if necessary in a given short period of time. And also the benefit here, as you listened, is that it's care closer to patient's home. In other words, is care provided at patient's home, in patient's own environment. When people come to our MS clinics, they are anxious. They've been waiting for the neurologist to be seen for maybe 9 months, 12 months, 24 months because of their whole national health services and pressures that we've got. Not necessarily people are being seen in a timely manner. That affects their performance, their anxiety and stress and everything else, and the examination during the clinical consultation takes maybe 10 to 15 minutes. It's very rushed, quick, swift assessment that, I'm not sure how accurate we are with that. And I think this tool might be a bit better in giving more better data for us to action. And I think what we could also discuss here, that the technical validation study, the phase 1 of PARAMS is just setting the foundation and making sure that the calibration is good, the tool that we use is adequate to capture these minor and bigger changes in people's performance, and then set the foundation for clinical phase 2 of PARAMS study. Would you like to comment a little bit? What does the phase 2 of PARAMS study involve? What is it? What's the difference between the technical validation and the clinical trial of PARAMS? So phase 1 versus phase 2.
Right. So very simply, phase 1 is just looking at how good a job the system does in terms of generating accurate, meaningful measurement of people's behavior. And we need to do this in the laboratory because we need our gold standard equipment with these shiny markers and the different sort of high-tech equipment, if you like, that we have in the lab. And this is just a means to an end to equip the PARAMS project to then take these devices into people's homes. So the primary project within PARAMS is going to be based in people's homes, where people are going to be using these devices, and we can start to look in a more meaningful way at how well the PARAMS device, how well those outcomes not only correlate or how well they're associated with current assessment, say with the EDSS, but we can also start to look at how well this device is reporting these outcomes in a meaningful way. So one of the nice things about this project, as far as I'm concerned, is it's not like most artificial intelligence projects or devices where you're trying to replace the human in the process. With the PARAMS project, we're really trying to provide a more meaningful set of outcomes that are ready for the interpretation by the clinician. So it's the artificial intelligence and the high tech working with the experts, the expert clinicians, so they have more information to go on when informing their decisions. So within the main project, we can collect information from the PARAMS tool in people's homes, and we can start to provide a basis for further development to refine this tool, so that it is ever more ready for meaningful clinical practice. And we're going to try and do this in a way where these developments can happen as quickly as possible, so the tool can make a meaningful impact as soon as possible.
I would like to just add that we are referring often during this episode EDSS, but there are lots of other biomarkers which indicates disease activity, which we will correlate with AR outcome measures, which only going to advance our decision-making processes, because we're not just looking at one variable and one parameter. We are looking at the whole person and variabilities and factors that influences disease activity or progression or both. So it's really fascinating what is ahead of us. And of course, the clinical trial involves even more effort, a larger team effort, and there will be research nurses involved, coming at the patient's home with a gadget, investigating immediate output is going to be sent to the researcher consultant neurologist who will interpret the results. And by getting that right, it involves a lot of human factor and effort to set up the study, the second phase 2. But it's really worth doing this, and we are very keen to go ahead and do all what's required to set up the trial and measure the outcomes and have the longitudinal data and assessment at the baseline, and the follow-up appointments will be used the same gear to produce the outcomes. And our also ultimate goal is to produce some friendly to read reports that takes only maybe 5-10 seconds for the neurologist to understand the output results based on the AR measurements. So it's on our work list to do that. So I think now maybe 70% of our listeners now thinking, oh my God, I would like to be part of this project. So how can I get involved? So Will, can you let us know next steps for the MS PARAMS study, and how can listeners get involved and support this fascinating research project?
Yeah, thank you. So at the University of Exeter, we're now in the final stages of preparing for the technical validation. And we will be recruiting people to come to the University of Exeter, to come into the laboratory where we put these shiny stick-on markers over different parts of participants on top of their clothes. And we ask them to use the PARAMS tool, so to do these different balance and walking tasks for the purposes of this phase 1 validation. If there are people listening to this podcast and you're thinking that you'd be interested in coming into the university and taking parts in this, then the best way to progress at the moment would be to just send me an email personally. My email address is w.young, Young, at exeter.ac.uk. If in doubt, you can just Google Will Young Exeter, and I'm pleased to say that I now trump Will Young the singer in the Google lineup. If you put Will Young Exeter, even though he's from Exeter, I now come on top. And my university webpage can be found there with my email address. So if you were to just send me an email, what I will then do is send you the participant information sheet once we have that ready. So that information sheet will tell you much more specific detail about what would be involved in participation, things like the arrangement for travel. We can pay up to £100 per person for travel to the university, whether it's to cover taxi or train travel or reimbursement for petrol, etc. The participant information sheet really lays out the details of what will be involved in the participation. So by sending me an email, you're by no means signing up for the study. You're just saying that you're interested in this type of work, and then I'll send you the information sheet, and then you can make an informed decision about whether or not you'd like to take part. Your email address by emailing me will only be used for the purpose of sending that information sheet. It won't be used for anything else. And in fact, once I've sent that information sheet, I'll be removing that detail from my computer anyway. So it's not like you're sending your email address that will be then used for lots of different things.
There we go. So you have now work email of Associate Professor Will Young. Please do mind his privacy and send emails only that are related to this project. So thank you very much for sharing. I hope that there will be a lot of interest, Will, coming down and being part of this project. I think overall, it's really hard to recruit patients sometimes to numerous amount of the clinical trials for numerous amount of factors and reasons. But if you have time, it's going to be one visit only. Will, how much of the time is required for people who are interested to contact and be part of this trial?
So typically, I would imagine that the visit itself would probably last for about 90 minutes to 2 hours, but that includes a lot of the time being allocated to rest periods. I mean, whether people want to or need to take a rest, a lot of the session will be us just having a largely informal discussion about what the different devices are, what they do, and a lot of people, I like to think, will find sessions like this enjoyable and interesting. So I'd say about 2 hours is a good approximate duration for the visit. But I'm also keen to stress that for all of the studies that we run, if anyone wants to stop at any point, then that's not a problem at all. They don't have to give a reason for it. And we always have, the arrangements in place where we can just very quickly end the session if people just feel uncomfortable for whatever reason. So hopefully that helps to put people's minds at ease in terms of apprehension in coming to these high-tech laboratories, because I understand it can be quite daunting, but I promise you we're all very nice, and if anyone feels comfortable, then we can just draw an end to the session and arrange travel back.
Yeah, it's a nice day trip to Exeter, a beautiful city in the Devon. So I think it's a nice opportunity, and it's probably, if you're coming from far away, it's going to be probably half of your day. If you are local in Exeter, so as you listened, it's a few hours, and then that's it for phase 1. Maybe let's cover a little bit before we finalize the eligibility criteria for phase 1. Who are the candidates that you're looking? Are people who are in a very advanced stage, or they still have a proper function? They can still walk independently, or they can use a walking aid? Who are these people with MS that you're looking to recruit for this study?
So the current application for ethical approval for the project states that that people will need to be able to stand independently for 1 minute. Now, it may be at the end of that 1 minute, you're really looking forward to having a sit down, but the criteria would be that for some of these tests, we do require people to stand unassisted, so without a stick, for a relatively short period of time, so 1 minute. When it comes to the actual testing session, if anyone really needs to sit down at any point, then of course you can do so, but that's a kind of a cutoff that we have if people feel comfortable to stand without assistance for 1 minute. And then the other criteria will be if anyone has significant problems with memory or cognition to the point where it might be difficult to give informed consent to take part. So I'm talking about substantial problems with memory, then that's also going to be an exclusion. So the third exclusion criteria for the technical validation relates to any neurological or musculoskeletal problem that substantially affects balance or walking. So this includes visual conditions, where if people are partially sighted or visually impaired to a point where their balance or walking is substantially affected, that is for the technical validation an exclusion. However, for the community-based study, the primary study within PARAMS, where we go to people's homes, we are looking to include people who are partially sighted within that study. It's just not something we can accommodate in the technical validation.
Wonderful. So people who are affected with optic neuritis and are partially sighted or are blind, they're not eligible for phase 1 technical validation study as yet. We will come back to you once we go into the clinical study, but not for this tech validation study at this time moment. And I understand age and type of MS is okay. So there's no limitation on what type of MS they have and how old people are. Is that correct?
That's correct. Yeah, as long as the criteria that I've just talked about are not an exclusion. What we're really keen to do in this technical validation is get a broad range of potential symptoms and abilities and ages, because if we keep this criteria too tight, then it may be that we miss certain behaviors. I mentioned about certain tremors or things that may be an issue or may cause an issue for the sensors to give an accurate reading. If we have a very broad range of abilities and ages, etc., then we're likely to be able to pick up on more of these things that might be a problem for the PARAMS sensors, and therefore help with the development to overcome those challenges. So yeah, it's very broad. We welcome a wide range of people as possible.
Mm-hmm. And they probably need to provide a letter from the GP doctor or maybe their neurologist that they have a diagnosis of MS. Is that correct? How can we identify that these people are not living with other alternative neurological conditions? They all have multiple sclerosis before they enter the technical validation study.
Yes, yeah. Thank you for mentioning that. Yeah, it is really helpful to us if people do have their letter from their neurologist detailing the diagnosis, as well as any information they have maybe about brain scans, any information that people can give us about the diagnosis and the documentation they have for that would be really helpful to us. But not having that letter is not an exclusion in its own right. So if for some reason people don't have that formal documentation, it doesn't exclude you from the study. It's just really helpful for us to have that information for us to help with the interpretation that we have of the information that we collect.
Overall, if you are a patient with MS and if you are extremely interested in being part of this clinical trial for phase 1 at the moment, Associate Professor Will Young is recruiting patients. There is no age limit. There is no limitation of what type of MS you are living. You need to be able to walk and stand without walking aid for a minute. So please do get in touch with Professor Will Young. His email address is w.young@exeter.ac.uk. Thank you for joining us today on this episode for Be Well with MS podcast. I hope you found our discussions very, very informative on the MS PARAMS phase 1 study, as enlightening and inspiring as I did. It was a great pleasure, Will, talking to you today, and special thanks to Associate Professor Will Young for sharing his expertise and insights into the potential of AR and motion tracking technologies in revolutionizing MS motor and cognitive function assessment. The recruitment is going to start very soon for PARAMS phase 1, and if you're interested in participating in PARAMS study or you want to learn more about this study, please reach out and contact Associate Professor Will Young at the University of Exeter. Your involvement could make a significant impact on the future of MS care. Don't forget to subscribe to our podcast for more episodes featuring leading experts and groundbreaking research in the field of multiple sclerosis. Until next time, I'm Dr. Agne Straukiene, encouraging you to be well with multiple sclerosis. Thank you, Will.
Thank you very much.